Good evening and welcome all. On behalf of Maharashtra Academy of Pediatrics, a very warm welcome to all my respected seniors and colleagues on Zoom as well as YouTube Live. Today's session of Maha Mentees has been granted 1 NMC point. And so, dear friends, please don't forget to put your name, central IIP and MMC number in the chat box. Dr. Sachin Ramchandra Vahadane from Ahmednagar is the MMC observer for today's session. Amol sir, can you see him? Has he joined?
No. He has not.
Okay. Friends, the topic for today's session is liver diseases in children. And according to the concept of this program, Mentor Mentees, today we have Dr. Ujjwal Podar from Lucknow as mentor and Dr. Vishnu Viradar from Pune, Dr. Dimple Jain from Thane, Mumbai, and Dr. Vibhor Borkar from Vile Parle, Mumbai as his mentors. But first of all, I would like to invite our Maha IP President, Dr. Hemant Gangolia sir, to give his blessings. Over to you, sir.
Thank you, madam. Good evening and namaste to the respected faculty, mentor, as well as mentees and office bearers of Maha IP, as well as I see Dr. Mahesh Mohite sir, as well as Secretary Dr. Amol Pawar, Dr. Renu madam, and all the dignitaries of the Maha IP, as well as the viewers on the Maha IP YouTube channel. This is the 6th episode of the Maha Mentor Mentees, and I distinctly remember Dr. Mohite sir, who was instrumental in making this concept in our Maha Pedicon 2021, which was held at Alibag, and from that we got inspiration, and we continued with this in this year. So this is 6th episode. Yes, liver is the main organ, and lots of liver diseases are there. We should be aware of that, and we are extremely fortunate to have eminent faculty Dr. Podar sir from Lucknow, as well as the eminent mentees Dr. Vishnu sir, Dr. Vibhor sir, as well as Dr. Dimple madam. And I'm sure with this extreme faculty, we'll be learning a lot, and we'll be having practical tips in our day-to-day practice as a pediatricians. And before I end, thank you very much and wish each one a very happy learning. I invite Dr. Mohite sir to say 1 or 2 lines as he is here.
Pallavi ma'am, kindly unmute Mohite sir.
Yeah, ma'am. Given permission. Mohite sir, kindly unmute yourself.
Yeah. Thank you very much, Dr. Hemant. Actually, I'm really, after a long time, I could join here because a lot of intensive care programs are there overlapping with this. But this is exactly what we wanted as a mentor-mentee. I think this is the best combination I'm seeing. Real mentor, and who don't know Dr. Podar sir. He has given just 2 talks in the past and he has become a national hit. He's amazing.
Mahesh, I was expecting this.
No, I'm yearning to get on the intensive care, but he's so busy, and but I'm going to get him. That's for sure. He has promised me a talk. And of course, the 3 trio, we have the best trio here, Vishnu, Vibhor, and Dimple Jain. What best you can add. So I just finished my work in time. I had to attend this program. Thank you very much for giving this time. Thank you very much. It's over to you.
Thank you, Dr. Mahesh, for gracing the occasion. Yes, Dr. Neha.
Thank you, Mohite sir. Thank you, Gangolia sir. Dr. Ujjwal Podar sir is professor and head Department of Pediatric Gastroenterology, SGPGI, Lucknow. Sir has done his MD from PGI Chandigarh, DNB Pediatrics, DM Gastro from PGI Chandigarh. He has received many national and international awards and has several publication and book chapters, both national and international. He has given guest lecture on both national and international platforms. He is reviewer of many journals and associate editor of Frontier Pediatrics, as well as section editor in Indian Pediatrics. He has also achieved one of the world's top 2% scientists in 2021. Welcome, Podar sir. Kindly unmute, sir.
Thank you, Neha. Thank you very much for your kind introduction.
Okay. The first mentees for today is Dr. Vishnu Viradar sir. He has done MD, PDCCI, Pediatric Gastro, and Fellowship in Pediatric Liver Transplant from UK. He has received ESPGHAN International Travel Exchange Award in 2018-19. He has many papers, posters, and publications in international and international platforms. At present, Sir is working as consultant pediatric gastroenterologist and hepatologist at Jupiter Hospital, Pune, and also at Kamal Endoscopy Center, Shivaji Nagar, Pune. Today, Sir will be presenting on chronic liver disease. Over to you, Sir. Kindly unmute and you can share your slides, Sir.
Yeah. Allow Zoom to share your screen. Give me a second.
Dr. Hemant and Dr. Neha, what will be the pattern? We'll have case presentation, then some discussion.
Yes, sir.
Yes.
After each presentation, we will discuss it, and then the second Mentees.
What will be my role?
You will guide the audience for that topic.
Okay, so
That has to be decided by mentor and mentees how to go about it.
no, we have not discussed before. This is on the spot.
Yes.
So it will be extempore. So Vishnu will present, then we'll have discussion at the end.
Yes.
Okay.
Yeah, give me a minute. Yeah. Can the screen, is the screen visible?
Yes, sir.
Yeah.
Yes.
Yeah. Good evening. Sorry for the hiccups, the technical one. I thank you, Maha IAP, and this is a good program, and it gives goosebumps of presenting a cases in SGPJ in front of our sir. And today, the topic which we want to discuss is the chronic liver disease cases. So what I have done is I have briefly summarized that what we think as a chronic liver disease when the patient comes to us, what should be the thought process, and then I give you the snaps of the two cases, and then we have comments and the suggestions from the sir. So what we expect from everybody is the minimum examination of the clinical features of liver, what is the consistency, what is the liver span, right lobe, left lobe, presence of spleen, ascites, any superficial dilated veins, and the flow if they are dilated and tortuous, and assessing growth. This is the minimalistic things we expect from everybody, and I'm sure that because of the busy practice in the office, we always tend to miss out the things. But if we try to do all these things in the office practice, then we will not miss many of the chronic liver diseases or any liver disease. So how do we classify it? Either it is a cholestatic disease, either is it a hepatocellular dysfunction, is it a metabolic disease, is it a storage disease, or it is just a benign jaundice, or are there any CLD mimics we should be looking when the patients of hepatosplenomegaly or the jaundice comes to us? So what are the things which come in the cholestatic syndrome? We all know about biliary atresia, PFIC, alagili, tyrosinemia, galactosemia. These are the cholestatic form, and usually they come in the first few years of the life. But there are hepatocellular dysfunctions like Wilson presenting after 3 years of age, autoimmune hepatitis age from any age, Budd-Chiari syndrome, which is very common in the Western India and majority part of certain Northeast India also. Hepatitis B and C infection, which we tend to see very less common as a presentation of chronic liver disease. NCPF or CHF like congenital hepatic fibrosis or non-cirrhotic portal fibrosis, sometimes they present with hepatocellular dysfunction also, but majorly they present with the portal hypertension. Metabolism disorders usually don't present with a jaundice or the hepatosplenomegaly, which are urea cycle defect, mitochondrial or Crigler-Nazar. The storage disease, which is commonest we see, is the glycogen storage disease. Gaucher's Niemann-Pick present with hepatosplenomegaly or though a splenohepatomegaly. We also see a cholesterol ester storage disease and mucopolysaccharidosis as a differential diagnosis of hepatosplenomegaly. which is not probably a chronic liver disease. And there are chronic liver disease mimics like hemoglobinopathies and muscular dystrophy. So this is by and large, we think about the etiology when we are seeing a patient of chronic liver disease. Asymptomatic jaundice child coming to us repeatedly with the just jaundice and bilirubin which is high. Either it is a direct component we see in Dubin Johnson and Rotar, or it is an indirect component we see in the Gilbert syndrome. And these are the children coming regularly to the pediatrician, visiting multiple gastroenterologists, just showing the bilirubin which is raised and the rest of the liver function test is normal. How can the chronic liver disease can present? One is they can be acutely ill. So in the newborn, they can be galactosemia, tyrosinemia, neonatal hemochromatosis, or in older children, it could be Wilson, autoimmune, Budd-Chiari as acute presentation. They can just present with jaundice, like all the differentials can just present with jaundice. They can also present with a cirrhosis or a portal hypertension. In the older children like Wilson, autoimmune, I talked about congenital hepatic fibrosis in less than 2 years and non-cirrhotic portal fibrosis in the older children. Budd-Chiari can rarely present with a cirrhosis. Tyrosinemia, missed tyrosinemia, or the other presentation of the small portion of presentation can be like a chronic liver disease, or just a hepatomegaly. The presentation is by glycogen storage disease or a CASD, which is cholesterol ester storage disease. So this is by and large how the chronic liver disease can present. So it is not dependent on the duration. They can be acute, they can be portal hypertension, they just present with jaundice, sometimes they just present with splenomegaly, they just present with hepatomegaly. So the all basket has to be open while we discuss or while we see the patient of chronic liver disease. So with this background in our mind, we will come to the real case scenarios. So this is a 3-year-old girl, had a jaundice since April 2020, just yellow eyes and urine, no fever, no anorexia, no vomiting, and she received Ayurvedic medicine for the jaundice, and then first time presented in June, and that time the pediatrician did some test. So there was no vomiting, no abdominal distension, and the test hemogram was normal. Liver function test was 5.3 bilirubin, 2.7 direct component, 400 is the SGPT, 850 is the SGOT, alkaline phosphate is 351, the proteins were 7.8, albumin was 4.8, and it was thought to be acute viral hepatitis. Done the ultrasound which showed echo poor liver with periportal echoes which are prominent, spleen is normal, there is a streak of ascites, gallbladder edema was there. The findings were noted to be a suggestive of viral infection. Second day, they did the liver function test. The bilirubin 6.5, the SGOT, SGPT marginally here and there. The albumin is 3.1, treated with IV antibiotics, IV fluid, the multivitamins, and child was discharged within a span of 3 to 4 days. So what was missed here? So is it acute viral hepatitis, or is there any pointer to the chronic liver disease? So why not it is acute viral hepatitis? The first and foremost thing is there was no viral prodrome in this child. And the child is having jaundice since April to the June. So any viral hepatitis has to improve over a period of 2 weeks. So any jaundice remaining more than 2 weeks. So our antenna should be up that why this child is having so much of prolonged course. And the third pointer which was there is the albumin at the time of discharge was 3.1. And these are the few pointers which were there. This child presented to us after a month in July, and this child had a persistence of jaundice, abdominal distension. She was sleepy in the daytime. There was fever of 5 days, weight of 15 kg and height of 97 centimeter. So this was the child, and this was the liver which was there. So 3 centimeter of liver which was firm on the right below right subcostal margin. The left lobe is 5 centimeter, which is more than the right subcostal, the right lobe, and there was ascites. So these were the child's liver function test. So first time we did the PT-INR, which was the 3.5, and the SGOT, SGPT was 300, and look at the bilirubin, which was gone up to to 13.9. So any bilirubin going beyond 5, 6 and persisting beyond 2 weeks. So majority of the time it is not acute viral hepatitis when there is no prodrome. So this child is already having some chronicity which was going on. So how did we progress or proceeded? So we did the viral markers which were negative. We did the ultrasound and the Doppler, which showed coarse ecotexture of the liver, gallbladder edema, there was ascites, hepatic vein, and IVC were patent. So how the child progressed over a period of 4 days? The hemoglobin was stable, the platelets were normal, the proteins were, if you look at it, 4.9 on 12th of July with albumin of 2.32 and the total protein of 2.49 on 17th. But look at the PTINR, which was consistently more than 2. So this is the child after giving vitamin K also not improved. So how do we like to approach in these patients? So this is a hepatocellular dysfunction presenting in a chronic way. This is not acute viral hepatitis. This is not acute liver failure. Maybe some acute insult in form of fever, which was there for 5 days, and that has made this child deteriorated further. And what investigations we want in any patients of chronic liver disease is what we wanted to tell you is we wanted to do the Wilson workup, we wanted to do the autoimmune workup. We have already done the Doppler to rule out the Budd-Chiari syndrome and hepatitis B and C syndrome. So we did the Wilson workup, ceruloplasmin was 13, the 24-hour urine copper was 30, ophthalmic examination was KF ring negative, MRI brain was done, there was no basal ganglia changes. We did the autoimmune workup, the immunoglobulin G was 2800, ANA was negative, SMA was negative, the liver kidney microsomal antibody was awaited, Budd-Chiari syndrome workup, Dopplers were negative, and infection we ruled out B and C was negative, A and E was negative. So this is how we work up in patients of chronic liver disease. When we think about what are the causes of most common causes are Wilson, autoimmune, rarely Budd-Chiari presenting with hepatocellular dysfunction, but majorly it present with ascites and hepatomegaly. MRI brain was normal. This child continued to deteriorate. We started steroids on 18th and 19th because the IgG was high, and though the ANA was negative, Wilson was ruled out because just ceruloplasmin was less, and the LK antibody came, which was positive. So this was the autoimmune liver disease, high IgG and LKM1 positive. We started this child on steroids, but because of the child deterioration and very IgG, the gastroscopy did not show any big varices, but there was portal hypertensive gastropathy. Colonoscopy, there was no ulcerative colitis. Because of this child was deteriorating, we given the both option of either steroids or liver transplant. The unfortunately child did not, the family did not accepted the liver transplant, and after 2 weeks, because of the infection, we lost this child. So what are the points which we learn in this case? So the absence of prodrome rules out acute viral hepatitis. Follow-up of the child in patients of the high SGOT, the high bilirubin needs to be very, very proper. What we missed probably is the high SGOT to start with. Low albumina and high PTINR should have raised the suspicion, but what we need to do is the PTINR in each patient. If we don't do the prothrombin time, we will not come to know is the child prothrombin time is normal or not. Low ceruloplasmin should not be considered as a Wilson because we need other tests. ANA unfortunately was negative in this child, but because of the high IgG, we did consider the autoimmune liver disease. The ideal thing is to go ahead with the liver biopsy, but because of the PTINR which was high and the ascites was there, and we could not able to do the transjugular liver biopsy in this child. So we started with the steroids, but unfortunately we lost this child. So probably liver transplant in this scenario may have helped, but I'm not sure about it. Poddar sir will put some comments when we will discuss about this case. Should I go ahead with the case?
I think Vishnu.
Yes, sir.
let us discuss this case because we have total 3 cases now. Already 20 minutes is gone. It's total 1 hour session.
Yes, sir.
So interesting patient. Do you want me to comment?
Yes, sir. Yes, sir.
Uh, I am your mentor, Vishnu, so you should not mind if I criticize you.
Yes, sir. Yes.
See, the message should not go that all patient who is having jaundice for 2 months and having coagulopathy is underlying chronic liver disease.
Yes.
There are the subset of acute hepatitis, like when patient develop decompensation after 4 weeks, you call it subacute liver failure.
Yes.
Okay, this child develop hypoproteinemia, hypoalbuminemia ascites after 2 months.
Yes.
Started with acute. So we should not. Fortunately, there was no viral marker. But in a
Right.
clinical setting, if you have a patient who has developed decompensation in the form of ascites or coagulopathy within 4 weeks, then you start thinking, is there any acute or chronic liver failure?
Yes, sir.
Is the acute insult or a chronic? Or everything is acute. Acute liver failure can have ascites. Acute liver failure can have, obviously, we will have deranged INR. So within 4 weeks, you will call is the either it is acute liver failure, or if you have a suspicion of underlying chronic liver disease because of this previous history or patient is having splenomegaly, firm liver, you start thinking of acute and chronic.
Yes.
If the patient decompensate after 4 weeks, like this, the index case, then there is the entity called subacute hepatic failure, where it starts acute, like acute viral hepatitis, and after 4 weeks, patient may decompensate in the form of ascites like this child. So
Yes.
in that case, you will get the acute markers.
Correct.
But if there is nothing, no acute, then obviously you have to think about everything is the chronic. This child has chronic, probably some acute insult, though it is not fitting with the acute and chronic liver failure, probably it was a chronic. Now there is a problem of diagnosing autoimmune in this kind of patient in a in day-to-day practice. What even Vishnu, being a specialist, could not do, we do because we have the better facility here, is a transjugular liver biopsy.
Yes.
That is the gold standard in diagnosing autoimmune hepatitis. Don't carry it away with the only IgG. IgG elevation is very highly non-specific.
Yes.
IgG elevation, you give importance when you the other serology and are negative. Still, then you have to go for liver biopsy to
Yes.
make a diagnosis. Regarding treatment, yes, this is a case of acute severe autoimmune hepatitis because L came positive, duration is less than 6 months. There was a coagulopathy. As per the new criteria, this is acute severe autoimmune hepatitis, not autoimmune liver disease. Autoimmune liver disease is an umbrella term
Yes.
that encompasses your autoimmune hepatitis, autoimmune sclerosing cholangitis, etc. Here we are talking about hepatitis, not autoimmune other. So it is an autoimmune hepatitis. So acute severe autoimmune hepatitis is when it is with duration is less than 6 months and having INR more than 1.5. But there is no encephalopathy. When there is the encephalopathy, you would call is the acute liver failure, autoimmune acute liver failure. So yes, the treatment-wise, steroid was on the card. After giving steroid for 2 weeks, if the patient does not respond or deteriorate, liver transplant.
Yes.
If you see the literature, more than 50% patient die on steroid. If you are lucky, the patient will improve, but most often they will need transplant than only steroid therapy. So message should be clear.
Yes, sir.
If you get this kind of patient, obviously you will work up for acute viral hepatitis. Any patient when the acute viral markers are negative, think about the chronic. This child didn't have any viral markers positive, usual common garden. We are not talking about the unusual viruses. A, E, B negative, and the patient behaving like this, there's a persistence of jaundice for 2 months, coagulopathy, think about underlying chronic liver disease. And being a girl at 3 years, obviously autoimmune hepatitis score high than Wilson. Wilson usually comes late. And one point about cerebral plasmin, Vishnu, you said the cerebral plasmin 16, 18. Remember, the single digit cerebral plasmin is important, means
Yes.
less than 10. When it is 2 digit cerebral, though the traditionally anything less than 20 is low cerebral plasmin, but when there is a synthetic function is poor, it is the acute phase reactant and it is produced by the liver. When albumin is low, 2.2, you are expecting all other protein will be low because that is synthesized by the liver. So cerebral plasmin 16, 18, 15, these are non-specific. You should not pay too much of attention. I don't think there is a merit of going for MRI brain in this patient. You have enough evidence to say that this is autoimmune hepatitis,
Yes.
right?
Yes. Yes.
So anything else from the chairperson, Dr. Mohite or Dr. Amal, Dr. Hemant?
Just from the clinical point of view, sir, Vishnu mentioned about dilated veins. In a pediatric patient, how sensitive and specific are they? How often you see in a chronic liver disease?
Vishnu, you will answer and then I will supplement.
Yes, sir. So just presence of superficial vein or a presence of dilated veins is not important. What is more important is dilated tortuous veins. Then it has a meaning of presence of portal hypertension. Specifically, it comes very handy in patients of Burch-Cherry if you get a back veins. So you get a back veins, ascites, hepatomegaly, and the flow from the down to above. So we suspect Burch-Cherry, but we have seen in patients of cholestatic disease, which we are following, like biliary atresia, which are followed. So after 3 years, 4 years, where they start decompensating, we get lot of dilated tortuous vein, but not in the routine patients of chronic liver disease. We see that much often.
Just one more point. How I would say sensitive specific is increase in the globulin levels. Like Vishnu, you showed AG ratio with a normal, reversal with a almost normal total protein. Can that be taken a good marker towards autoimmune hepatitis?
So there are certain subtle clues, but it is not a good sensitive marker, because if you see that with all these tests in hand, still we are confused about the diagnosis. Till we get a liver biopsy to label autoimmune liver failure or the autoimmune hepatitis, in this kind of scenario becomes very difficult. So there are clues to add, and then retrospectively it is very easy to score the system. But when the child comes to you from that day onwards, when the every test is coming, some tests come after 3 days, some tests come after 5 days, some are the, and the child is deteriorating in front of you. So that time to make a diagnosis, it becomes very, very difficult. But yes, if the globulin fraction is high, that increases your suspicion about autoimmune phenomena.
Just last question to
Yeah,
Dr.
can I supplement, Dr. Mahesh?
Sure, sir, definitely.
What Vishnu said, I fully agree. The dilated and tortuous vein is more important, just a prominent vein. A child is having abdominal distension due to organomegaly or ascites will have some vein, so that is not important. Secondly, Vishnu talk about the back vein. Usually back veins are seen when there is a IVC obstruction. I don't think the Budd-Chiari was high on this card in this child who started with hepatitis. You don't consider Budd-Chiari when there is a hepatitis. You consider Budd-Chiari when there is a disproportionate ascites with hepatomegaly with veins. So that is besides the point. But the globulin is what Dr. Mahesh you are hinting at is very important question. Any chronic liver disease, traditional teaching, AG reversal, albumin globulin reversal. That means albumin is low, globulin is high. So that is not specific for autoimmune hepatitis. And that's why to diagnose autoimmune hepatitis, we need multiple factors. That simplified diagnostic criteria, you need the high globulin, you need the autoimmune marker positive, you have to rule out the viral hepatitis, and then your biopsy. So taking everything together, you make a diagnosis. Just on the basis of one parameter, you cannot. That's why Vishnu was not confident in diagnosing this patient until he got that LKM positivity. Yes, next, Dr. Moyes.
No, that's all, sir. I think you mentioned about one of the scores for diagnosing autoimmune hepatitis. total 8 points, of which 6 should be positive. But still, that may not. I recall in one of your talks.
Yeah,
So
yeah. This is simplified diagnostic criteria for autoimmune hepatitis. It is very simple.
Yeah.
You need just 4 criteria. If there is a IgG, which is you need not globulin, you need the IgG level. It is just above upper limit is 1, but if it is more than 1.1 upper limit of normal, you give the 2 score. Then you have autoimmune marker positivity depending on the titer. You give the low titer is 1, is more than 1 is to 80 of SMA-ANA, you give 2. Similarly, hepatitis B, C negative, you give 2 score. And liver biopsy, if it is a characteristic, you get 2. And if it is a suggestive, just interface hepatitis, then you give 1. Now, add up is total 8 score. Patient has to get at least 6 to say it is a probable. But if it is a 7 or above, then only it is definite. So you have to be very careful in putting a level of autoimmune hepatitis, because if it is not autoimmune hepatitis, the treatment may be detrimental.
Yes, yes.
Thank you, sir.
Should I go to a quick case of 2 or 3 slides?
Yeah.
Yeah. So this is a one and a half.
Vishnu, short, otherwise you will not be able to finish. It's already 34. So make it short so that we can have a good discussion.
Yeah. So this is a 1.5-year-old boy with abdominal distension, nothing else. Hepatomegaly 5 centimeter below right subcostal margin. This was the abdominal distension. No other symptoms. No loose motion, no voracious appetite, no aversion to sweet or any type of diet. The bilirubin is normal, SGOT, SGPT 132, 154, proteins were normal, PTN are normal, hemogram normal, the CPK normal, creat normal, cholesterol 154, triglyceride 302, VLDL 60, HDL 42. So I thought, okay, this is a storage disease, probably glycogen storage disease. We did the biopsy, and the biopsy showed there is a macrovesicular stenosis. This retic stain showed little bit of fibrosis, empty stain showed the same, and pass diastase did not pick up anything. So this was a fatty liver. We sent the clinical exon, and it showed it is the transient infantile hypertriglyceridemia. So this was a transient infantile hypertriglyceridemia and having a fatty liver presenting just with hepatomegaly. So just a brief thing, most common cause of hepatomegaly with short stature, with chubby cheek, we think about glycogen storage disease. So sometimes you get a something else. Liver biopsies gives a better clue. You do the pass stain and pass diastase. So if it is a glycogen, you will get glycogen. If it is a fat, you will know it is a something else. And really clinical exon sequence or whole exon sequence has played an important role in diagnosing this rare disorders. That is what we learned from this case. Thank you.
Vishnu,
Thank you, Vishnu sir. Yes, sir.
Just one comment. Vishnu, this is a forum about general pediatrician. I don't think we should give a message that all patients with hepatomegaly we should go for exon sequencing.
Yes.
This is a rare disease.
Yes.
To diagnose rare disease, you need to do the rare test.
Yes.
But the rare disease doesn't come every day in, day out.
Yes.
Next patient will come to you with hepatomegaly, you will
We'll think about glycogen storage.
GSD only.
Yes.
And their exome sequencing may pinpoint a particular variety, but to make a diagnosis, you don't need it because it costs 20,000 rupees. So, yes, to diagnose rare disease, you need rare test, but day-to-day practice, again, I will stand by hepatomegaly, hypoglycemia, hypertriglyceridemia, GSD is more common. Even if you get the fatty liver, you can get HFI or cholesterol ester storage disease like that.
Yes.
But, right, okay.
Yes, thank you, sir.
Thank you, sir. It was a very nice presentation, both the presentations. Thank you, Vishnu, sir. Yes, now the second mentees will be Dr. Dimple Jain. She has done MBBS, MD, MRCPCH, PDCC, and visiting fellowship pediatric hepatology from King's College Hospital, London. At present, she is consultant pediatric gastroenterologist and hepatologist at Jupiter Hospital, Thane. Welcome, ma'am. Please unmute and share your slides.
My slides are visible?
Yes, ma'am.
Thank you very much, Maha AP, for this excellent session. Thank you, Dr. Hemant Gangulia, sir, Dr. Amol Pawar, Dr. Mohite. It's a great opportunity to speak again in front of our mentee, Dr. Podar, sir. So, yeah, I'll try and do my best. So, I'll be presenting on neonatal cholestasis and approach. Sorry. So what is cholestasis? So as the word says, cholestasis, so basically stasis of bile, which is physiologically any decrease in bile flow, or pathologically if you see bile pigments within the hepatocytes or in the bile ducts, and clinically as accumulation in the blood of either bilirubin, bile acids, or cholesterol. So to define neonatal cholestasis, any prolonged elevation of conjugated bilirubin beyond 14 days of life. If it is more than 20% of total bilirubin when the serum bilirubin is more than 5, or more than 1 milligram percent if the serum bilirubin is less than 5. And incidence, if we see, it accounts for almost 1 in 2,500 live births, of which the most common is biliary atresia, which accounts for almost 30 to 40%. So coming to our case, this was a 52-day-old boy, firstborn of a non-consanguineous marriage, who presented with complaints of jaundice, which was noticed by the parents around 1 month of age. The child came to medical attention because he developed a vaccine site swelling just 5 days prior, and there was fever for 3 days. So he was born of a term vaginal delivery with antenatal postnatal period was uneventful, average birth weight was well till 1 month. And then the parents started noticing gradually progressive jaundice with high colored urine. So this is a very simple thing, but I just want to, because we have a mixed crowd, so just significance of urine color in jaundice. So that helps us to differentiate between conjugated and unconjugated hyperbilirubinemia. If there is high colored urine staining diapers, we think of conjugated hyperbilirubinemia. And if it is clear urine, it's unconjugated. So this child, 5 days prior, developed a swelling on the vaccine site, and then he had excessive crying and fever. For these complaints, he was taken to the pediatrician. There was a hematoma which was found. The child was hospitalized. He was told that there is some derangement of his blood parameters. He received one FFP, was given IV antibiotics. The fever subsided, and then he was referred for further management. So this is a child, 52-day-old, with neonatal cholestasis with coagulopathy. So how do we proceed further? So we know there is jaundice with high colored urine. The next question we have is the color of the stools. So on inquiry, when the child was hospitalized, this was the stool color. And then we also showed the mother these stool color charts to find out where exactly was the stool color. She was not able to say exactly where, but between 3 and 4. And even if this stool color we see it is between 3 and 4, it is ambiguous, more towards pigmented. So it's very important to always show the mother a stool color chart, and also when the child is hospitalized to see the stool color ourselves. So what is the importance of stool color in neonatal cholestasis? Persistently pale stools, if we see consecutive stools which are persistently pale, it points towards a large bile duct obstruction, mainly biliary atresia. The second question that we have is whether it's a well infant or a sick infant. So what is a sick baby? So baby with refusal to feed, failure to thrive, any history of hypoglycemia, seizures, any previous SIP death. This child was accepting feeds well. There were no seizures, no hypoglycemia. Only for the last 2 days when the child had fever, he was a little dull, but otherwise well child. So when it's a well child, the cause is more likely to be biliary, either extrahepatic or intrahepatic. And if there is a sick child, then we more likely to be hepatocellular, like metabolic or sepsis. Coming to coagulopathy, whether it's a correctable coagulopathy or an uncorrectable coagulopathy. So coagulopathy can be seen in cholestatic disorders, but what we want to know is whether it got corrected post 1 dose of IV vitamin K. We typically give 5 milligram IV vitamin K, and we check for the INR again after 6 hours. So if the INR is corrected, then it points towards a biliary pathology. And if it's an uncorrectable coagulopathy, then it will go towards the metabolic causes or advanced disease. This child was actually given FFP once 5 days prior and then vitamin K. When the child presented to us, the repeat INR was normal. So it's a correctable coagulopathy. On examination, his weight was 3.9 kg. So he had gained almost 20 grams per day. which was average. His vitals were stable. There were no dysmorphic features or cataract. His liver was 3 centimeters palpable and firm. Spleen was not palpable. There was no ascites. Cardiovascular system was normal. His investigation showed a hemoglobin of just borderline hemoglobin 10.5. Rest was normal. Bilirubin with a direct component of 5.2, slightly elevated enzymes. What is of note is the INR, which was normal, less than 1.3, and a GGT. So it's very important to always ask for GGT in any child with neonatal cholestasis, the importance of which we'll come to in the subsequent slide. So this child's GGT was 65, which is normal. His ultrasound was done. We did a 4 hours fasting ultrasound. So that just showed hepatomegaly. The gallbladder was distended and post-feed contractility was present. CBD was normal. We always need to ask for a 4 hours fasting ultrasound, because an ultrasound in the post-fed state, the gallbladder will be contracted and that will not help us. The reason we do ultrasound is to look for gallbladder size, look for gallbladder contractility, look for any triangular cord sign which might point towards biliary atresia, look for dilated CBD to rule out choledochal cyst, and to look for any other anomalies which might be present like asplenia. Then Haida's, this child, since he had ambiguous stools, so as we saw, the stool color was between 3 and 4, and the GGT was normal. So here our suspicion for biliary atresia was low. And in the presence of ambiguous stools, Haida scan has a role. So Haida scan was done, which showed dye, which was seen in the intestines, thus ruling out biliary atresia. His GALT levels were done, which was normal, and serum alpha fetoprotein was done, which was 1600. So just one point. So serum alpha fetoprotein, though if we see the normal, we'll feel it is high, but what we see in babies, we have these normograms in which we see, as per the age of the child, we plot the alpha fetoprotein level. So we have normograms for both term babies and preterm babies. So how do you go about? So in any child with prolonged jaundice for more than 2 weeks, first check bilirubin with a direct component. If the direct is more than 20%, it's neonatal cholestasis. Just check if the child is well or if it's a sick child. If the child is well, the next is the stool color. So as we said, if we have persistently pale stools, then we have an urgency to work up for biliary atresia. We will come to that again. So next we do a 4 hours fasting ultrasound and a GGT. And then depending upon the findings, we'll go ahead with a liver biopsy and intraop cholangiogram. If the stools are pigmented, then the next thing that we want to know is the GGT, because that helps us in making our differentials, whether it's a low or normal GGT cholestasis or a high GGT cholestasis. A low or normal GGT will tell us whether it's a familial intrahepatic cholestasis type 1, 2, 4, 5, and the list is expanding, and the bile acid synthetic defects. And if it's a high GGT cholestasis, then we think of Alagille syndrome, PFIC type 3, and more, confirmation of which is by genetic studies. The role of Haida comes in when there is an ambiguous stool color, as we said. If the Haida is excretory, it rules out a biliary atresia. A non-excretory Haida may be biliary atresia or may be other causes of neonatal cholestasis. And if there's a prolonged jaundice with a sick child, then our differentials are different, as we said. So we can think of urosepsis, we can think of viral infection like herpes simplex virus, ecovirus, enterovirus, metabolic disorders. We have to rule out galactosemia in these children, because this is one condition which is easily treatable if diagnosed in time. And if it is missed, it can be life-threatening. Others like tyrosinemia, lysosomal acid lipase deficiency, some storage disorders can present with a sick neonate, with especially Niemann-Pick's type C. Then other disorders like HLH and gestational alloimmune liver disease can present with a neonatal onset cholestasis. So these are the various investigations that we do when we suspect. What's important for these viral diseases is there's no role of IgG. What we prefer is to do a PCR. For an important word of caution, just a CMV PCR does not make it a CMV. Hepatitis and neonatal cholestasis cannot be attributed just to that. We have to work up for other conditions, because CMV may be just a bystander. And we do not want to miss the opportunity to diagnose a biliary atresia or other metabolic disorders just because CMV PCR came positive. For galactosemia, we can send urine non-glucose reducing substances, 3 consecutive samples, and a GALT level. Very important because a lot of galactosemia is present with anemia. So before giving blood transfusion, the sample should be collected and sent for the GALT levels. For tyrosinemias, we send alpha fetoprotein, and if high, we can send urine succinyl acetone and plasma aminoacidogram, and then work up for the storage disorders and HLH. So this slide I've just put up to, this is from Hepatology 2022, recent paper, just at the ever increasing list of etiology of cholestasis in neonates. The list is ever expanding. Every year the paper changes and there are a few more genes which are added, probably because of the more and more genetics being ordered. So these are various etiologies of the low GGT cholestasis, hepatocellular causes, and the cholangiocyte causes of low GGT and high GGT cholestasis. So this child's whole exome sequencing was sent because it was a normal GGT cholestasis with a excretory HIDA. So our suspicion was a familial intrahepatic cholestasis. He had a compound heterozygous mutation of ABCB11, so confirming a diagnosis of PFIC type 2. The next thing that we want to know in babies with neonatal onset cholestasis is if there is any pruritus. Especially, we will be able to see in infants who are more than 4 to 6 months of age. The differentials for pruritus is typically seen because your bile acids increase in your circulation. So typically you will see in PFIC, Alagille syndrome, alpha-1 antitrypsin we don't see in our part of the country, choledochal cysts with cholangitis. Typically it is absent in the bile acid synthetic defects, metabolic liver disease, and biliary atresia. So now we're just going to discuss about pointers towards an early diagnosis. A child presents with cholestasis, what are the pointers which can help us to narrow down our differentials? So if we have decompensation, that is coagulopathy or ascites within the first 2 weeks of life, then these are our differentials. Gestational alloimmune liver disease, because as the name suggests, it's a gestational disease. So it starts intrauterine and the liver is already cirrhotic by the time the child is born. Then herpes simplex virus and other viruses like Eco-enterococcus virus and HLH. The other metabolic disorders, they take some time for the metabolite to accumulate, like galactosemia, tyrosinemia. So they typically present around the 2nd to 3rd week of life. Then we ask for antenatal history. We ask for history of pruritus in the mother during the antenatal period. Also, when pruritus on oral contraceptives, we look for genital vesicles in the mother to look for HSV. If there is any oligohydramnios, then that can be a pointer towards neonatal hemochromatosis. On examination, what we want to look for is cataract, growth failure, if there is early decompensation, hypoglycemia, seizures, anemia. These may all point towards galactosemia. Why we want, as I said, why we want to diagnose galactosemia in time is because if diagnosed, the treatment is very simple. We stop the lactose containing formula. We start on soy formula and these children do extremely well if diagnosed in time. If you have recurrent vomiting, poor growth, features of rickets or renal involvement, it may point towards tyrosinemia. If on examination you have a very large spleen as compared to the liver, it may point towards the storage disorders, especially Niemann-Pick type C can present in neonates with cholestasis. Then if you have history of parenteral nutrition, so cholestasis can present in up to 20% of newborns who have received TPN for more than 2 weeks. And trisomy 21 can be associated with paucity of bile ducts. Again, as we said, low or normal GGT, so these are the differentials. If you have severe uncorrectable coagulopathy, rickets, tyrosinemia, if you have liver failure with low enzymes, this is again because, as we said, neonatal hemochromatosis, that is a GALT, gestational alloimmune liver disease, begins in utero. And by the time the child presents, they are already cirrhotic and their liver enzymes may be quite low, less than 100, 50 to 100 typically. And if you have very high transaminases in thousands, that can point towards a viral etiology like herpes simplex, CMV. So coming to the most common feature, that is biliary atresia. So what is the utility of investigation? I'll just spend some time on biliary atresia. So the investigations in biliary atresia. So any child with persistently pale stools, we have an urgency to diagnose biliary atresia. So these are the investigations which we might order. Now ultrasound. What, as we said, we need a fasting ultrasound. It does not definitely make a diagnosis of biliary atresia, but it can point towards it if we have a contracted gallbladder, if we have a non-contractile gallbladder, if we have a triangular cord sign positive, and also it helps to look at other anomalies. GGT, as we said, high GGT can be suggestive of biliary atresia in the presence of pale stools. However, there are 5% of biliary atresias who can have normal GGT cholestasis. Liver biopsy is the gold standard for the diagnosis of biliary atresia. Sometimes it may not be done very early during the course. It may not show all the features of biliary atresia. However, it may also help us to diagnose other disorders. HIDA scan. We'll just come to the role of HIDA shortly. So as we said, HIDA has been overhyped in the diagnosis of neonatal cholestasis. HIDA, in the presence of persistently pale stools, what we have been taught is your eyes are HIDA. If your stools are clay colored, and persistently clay colored, there is absolutely no role of HIDA scan, because you know the HIDA will be non-excretory. The role of HIDA comes in when you have ambiguous stools and your suspicion of biliary atresia is anyways low, but you want to be sure. So if you detect an excretory HIDA, then that rules out obstruction and rules out biliary atresia. Duodenal aspirate, which is not done, and MRCP and ERCP are also not done. Role of ultrasound, as we said, the triangular cord sign, which is basically what we see is, we see a cord-like structure anterior to the right portal vein, and if it is more than 4 millimeters, abnormal gallbladder morphology on 4 hours fasting ultrasound. And an important thing to remember that a normal gallbladder does not exclude biliary atresia, because there is something called as a ghost gallbladder which can be present. Hence, what we also want to know is, in addition, we want to know that if the gallbladder is normal, we also want to know that the gallbladder is contracted after a feed. So post-feed ultrasound is very, very important, and we have to document at least a 60% contractility in the gallbladder size. Also, ultrasound can help us detect a choledochal cyst. Role of MRCP, as we said, though we have seen a few advising MRCP, no definitive role, I would say, not very sure. It can help us in diagnosis of other biliary tract abnormalities like a choledochal cyst, but the role in biliary atresia is of limited. HIDA we already covered. Why we don't want to waste time in HIDA is because HIDA needs priming. At least 3 days of UDCA it needs. And then again, another 24 hours delayed scan. So we'll waste 5 precious days in the diagnosis of biliary atresia. Hence, if the suspicion of biliary atresia is high, it is rather preferable to go ahead with a liver biopsy, or if the suspicion is very, very high, to go ahead with an intra-op cholangiogram rather than waiting for HIDA. So gold standard is intra-op cholangiogram and histological examination of the duct remnant. So why the hurry in the diagnosis of biliary atresia? So there have been various studies which have said that timely diagnosis and management will predict response to the Kasai hepatico potoenterostomy. So if it is performed less than 60 days of life, it has a 70% success rate. And after 90 days, it has less than 25% success rate. Now, this is a very nice diagram. Sorry, it is a little fade. But on the y-axis, that is the survival of the native liver. On the x-axis, we see time after Kasai surgery. And these various graphs are at age at which Kasai surgery was done. So this orange graph shows the one in which no Kasai was done. So almost all of them die by 2 to 3 years of age. And if the Kasai is done less than 30 days of life, then almost 50% of them will survive with their native liver at around 13 to 14 years of age. And as the age of Kasai increases, the survival of the native liver gradually comes down. Hence, if the biliary atresia is diagnosed in time, which is very simple, when the child comes up, we have to show the stool color chart, look at the pale stools. If there are pale stools, refer urgently for further evaluation. Do we have time, sir, or should I stop at this?
Dimple, I think we don't have much time. You can just sum up. And then,
okay, so
instead of going in detail of PFIC,
I just put up this slide to just show that the number of PFICs are going on increasing, probably because of the genetic, more and more genetic testing, and we are now more and more aware of the, So I think key messages that I would like to give is persistent jaundice beyond 2 weeks of life needs evaluation. Ask the mother about stool and urine color during a routine visit for a timely pickup. Suspect biliary atresia in well-thriving jaundice babies who have persistently acolic pale stools. A prompt decision for surgical intervention for biliary atresia, preferably before 60, actually they say before 30 days of life now. Give IV vitamin K. This is another point that I would like to make, that we should give IV vitamin K to every cholestatic baby at the first visit itself. The reason being they have a coagulopathy and they can have intracranial bleeds if it is missed. So that can be life-threatening. And we should have a low index of suspicion for treatable metabolic disorders, especially galactosemia. Thank you. Over
Thank
to
you, Dimple. Very good. Excellent presentation. Um, you rightly highlighted the one fact that in day-to-day practice, we should not forget about using GGT. The gamma GT is very important to differentiate the various causes of neonatal cholestasis. But in the algorithm, I will not put the gamma GT in isolation. When the baby comes with a cholestatic jaundice, as a part of liver function test, you do gamma GT. High gamma GT, obviously biliary atresia is one of the DT. Low or normal gamma GT, you are more worried about this normal gamma GT rather than high gamma GT. High gamma GT is highly non-specific. Any form of neonatal cholestasis, you get high gamma GT. But if you have a normal or low gamma GT, then you have to think about this newer entity called progressive familial intrahepatic cholestasis. We started recognizing more and more. One more thing I want to just add about this torch infection. This is a too much of hype. We should not spend money on torch. If you see the 100 patient of neonatal cholestasis, less than 10% maybe or less than 5% will be torch. And more importantly, that just positive, even IgM CMV positive is not diagnostic of congenital CMV. See, the perinatal CMV infection is much more than congenital. So a baby, that's why the strict criteria. If you have to diagnose congenital CMV, you have to do urine PCR or salivary PCR within 4 weeks of birth. After that, you cannot differentiate it is a congenital or perinatal. Congenital CMV will have problem with the different organ. That's why you need to do MRI brain, or they have this, if you have a liver biopsy with infusion, blah, blah, blah. So the in common practice of a baby with cholestasis going for torch doesn't make any sense at all. What happened, the many times you get something or the other positive, either CMV or herpes or some other virus out of torch will be positive, and we will keep on chasing that virus. We'll forget the original diagnosis. There are reports, people have chased the CMV, don't pay attention to biliary atresia, patient develops cirrhosis, require liver transplant. So don't waste money on torch infection. And another new thing, this is not new thing actually, we don't recognize often. Many of the biliary atresia you will get a cyst at both. So don't get confused, those are choledochal cysts, because the outcome is different. Cystic variant of biliary atresia need urgent surgery within 60 days. Choledochal cyst, even if it is deferred at 2 months, 3 months, the prognosis is still better. Most of those cysts are actually biliary atresia. So you have to be careful interpreting. Don't delay the surgery thinking that this is choledochal cyst, and your surgeon colleague will say, let's wait for 6 months or 1 year till the baby become 10 kilo. Absolutely no. Then by the time the baby will develop. So even it is a choledochal cyst, in infancy they behave like biliary atresia. They progress fast, they develop cirrhosis fast. So don't get confused about that. Rest of the thing is fine. Sick baby, healthy baby in day-to-day practice. Sick baby, obviously, Dr. Mahesh is there. They'll go to intensive care. You have to think about metabolic liver disease and infection or HLAs, etc. Healthy baby, the newer entity, the gamma GT is going to help. That low gamma GT PFIC. Thank you. I think, can we take a few questions or any query?
Yes, sir. There is one question in the chat box. How many copies of CMV in urinary PCR are considered for treatment with ganciclovir in a child with cholestasis?
Sorry, I didn't get the question. Dimple, would you like to answer, or do you want me to answer?
Basically, as Sir said, that CMV PCR, even if it is positive, so if it is after 4 weeks, it is positive, we do not know whether it is congenital CMV at all. And also before that, just because CMV PCR is positive, we should not trace that, because it could still be biliary atresia, it could still be other metabolic disorders, and we need to actively look for that. There are very specific indications for treating of CMV hepatitis, that is if you have end organ damage. So if your liver biopsy shows giant cells, or if your brain imaging is showing involvement, then there is an indication for treating CMV hepatitis. Otherwise, there is no role, because CMV is most of the times it resolves on its own. And our main worry is it can lead to long-term damage like deafness. Sir, you'd like to add?
No, you address the main issue. The CMV PCR positivity in the urine within 4 weeks, these are the subset who will have some impact of long-term valgus circulation. You have to give 6 months, and the improvement is mainly in terms of slight improvement in the hearing and probably reduction in the mental retardation. But as far as the organ damage is concerned, neonatal hepatitis part, we don't have any data to say that by you treat with ganciclovir, valganciclovir, they improve. Before starting therapy, you need to look for the involvement of the brain. That's why MRI brain is a must, and checking the hearing to decide whether it is a congenital CMV affecting the brain. And that is the subset probably you prefer to give long-term valganciclovir to improve their hearing part. But for just plain and simple neonatal cholestasis coming with IgM CMV positivity, don't chase the CMV.
Any other question, Dr. Neha?
Yes,
There are few questions for Vishnu, sir, but we will take it later on. Okay, can we proceed for the next sentence?
Thank you
Yes,
very
yes.
much, sir. Yeah, thank you.
Thank you, ma'am. You have presented the neonatal cholestasis very beautifully. Thank you, ma'am. Now our next mentor is Dr. Vibhor Bodkar. He has done MBBS from KEM Hospital, Mumbai, and PG from PGI Chandigarh. PD, CC, and DM Pediatric Gastroenterology from SGPGI Lucknow. Sir has various achievements, awards, papers, publications on his name. At present, Sir is Director, Pediatric Hepatology and Gastroenterology, Center of Liver, Pancreas and Intestine Transplant at Nanavati Max Super Speciality Hospital, Vile Parle, Mumbai. Welcome, sir. Please unmute yourself and you can share your slides.
Is my screen visible?
Yes, sir, it's visible. You have to only zoom it.
Okay. Hi, good evening, everyone. And I will like to thank Maha IIT Forum for giving us opportunity to present cases. And this is probably very wonderful concept of having a mentor, and that too like Poddar sir, and guiding this session. So I'll go ahead with the third topic, that is acute liver failure in children. And so in this, I will just show a clinical case. We'll go through understanding of the definition, etiology, workup, and the goals of the management, and what happened to this case. So here we had an 8-year-old boy who had jaundice, which was going on for 3 weeks. And later on, he was being investigated, treated on OPD basis. And before presentation, he had is documented that INR was increasing, but this child was being treated on OPD basis, and then he had encephalopathy before presentation. So on other details, he didn't have any past history of liver disease, no history of any medication use, and this child was developmentally normal. When he was admitted at that time, he had if you see his bilirubin was very, very high. The enzymes were in 1000, and SGOT was more than SGPT, and his INR was uncorrectable. After vitamin K also it was very high. And this parents are also not ready to get admitted at the initial stage. So when this child came for admission, he was already had advanced encephalopathy and got admitted. So if you see, we here we are dealing with the child who has a liver failure because this child has encephalopathy. But the definition in the pediatric population for encephalopathy is not only the presence of encephalopathy. The important aspects for the definition are we should have a biochemical evidence of liver injury. In the presence of encephalopathy, when INR is more than 1.5, it's fulfills the criteria. But if in the absence of encephalopathy, INR is more than 2, still it is a significant liver dysfunction. Duration of the illness less than 8 weeks and no known liver disease. So when all these things are getting fulfilled, so the diagnosis of liver failure is made. So doing an INR is very important when you are dealing with the child with the new onset, with the jaundice and liver dysfunction. So etiology wise, it's quite varied. Most common cause is a viral infection like A and E, B, but other viruses like CM, herpes, CMV, they're more common in the early neonatal age. Other causes like drug induced are also important. Autoimmune liver disease, just I think Vishnu has presented the case. Sometimes acute Burkieri, I mean, sometimes even the malignancies can present as an acute liver dysfunction. So if you see the Western literature, a predominant portion cases are indeterminate. And this is age-wise also there is a different distribution. In the Indian cases, if you see the viral infections like A and E are most common and contributing to 60 to 80% of the illness. But in the West, that portion is very small, the 4%. So gradually also in India also we are getting the other etiologies when we are able to investigate extensively. In neonatal age group, the causes are different, like there are herpes simplex infection. Metabolic again is an important causes like galactosemia, tyrosinemia, again gestational autoimmune diseases, septicemia, HLH, mitochondrial disorders. There are also etiologies we should work when there are neonates who are having liver failure. Now, knowing etiology is very important because that tells us about the prognosis, that helps us to decide the treatment strategy and the need for emergency liver transplant if required. So if you see the younger age group, the etiologies are like herpes simplex, metabolic liver diseases, HLH. In the toddler, it's a more of a metabolic infection, and indeterminate etiologies are present in all the ages group. And in the older kids, it's like an Wilson's, autoimmune, and again the metabolic and viral infections, they are common. So if we have a particular etiology, if we have any ischemic less likely. However, there are some illnesses like mitochondrial disease. Either doing the liver transplant or is not beneficial, or the patient are unlikely to.
Before you have some audio problem, check the connection. Your voice is getting interrupted. We can't hear you.
Vibhor sir?
Dr. Beaver seems freezed. Somebody can call him.
I'm calling him.
Till that time, Neha, any questions are there? Dr. Vishnu can answer that time, by that time.
Yes, sir. We have one question for a few questions for Vishnu, sir. One question is, Vishnu, sir, are you getting more cases of hepatitis, that is adenoviral, after COVID? Is it a part of MIS?
At present, we are not doing the adenovirus. And I think we are not seeing that much surge, what is reported in the literature. But saying so, we have started doing one study with the NIV from Pune. And probably in next 6 months or 1 year, we will come to a conclusion that is there any adenovirus which was there in the patients of hepatitis. But at present, I'm not seeing it. Maybe Poddar sir can highlight.
So Vishnu, the problem is that this adenovirus, the serology is not available. Neither it is commercially available, not in our institute. But we have to keep your antenna open. Those cases of viral hepatitis, looks like acute viral hepatitis, but you are not getting a positive serology. That could be a adenovirus. See that normally they are benign type, they recover, but a proportion of them can develop liver failure, like our hepatitis A or hepatitis B. So to pinpoint the diagnosis, we need the serology which is not yet available. Probably if you tie up with the National Institute of Virology, probably you may get some answer. But
Yes.
right now, we have started getting few cases where we are getting viral markers negative. Maybe that they are the cases with adenovirus. Most of them are milder form.
Okay.
Yes, sir. Vibhor sir, are you able to?
Vibhor, are you back?
Again, he is freezed.
Actually, he is logged in, sir, but not able to speak.
Yeah,
I think
hello.
the network issue is there.
Yes, sir.
Yeah,
Yes,
Sir, are
he
you
is
able
there.
to
audible
share?
now? Yeah.
Yes,
I
yes,
think it
you are
either
audible.
screen was disabled.
Sir, your bandwidth is low. You can stop your video.
Now,
Yes, sir. It is visible.
okay, yeah. So, so I don't know from which slide I was lost.
Trying pyramid one.
Triangle, pyramid.
Pyramid one.
Okay, got it. Yeah, so here the etiology is like few etiologies. So knowing etiology is important because few are treatable, means they have spontaneous recovery, like hepatitis A. If managed well, they can recover. In few, they will need a transplant, and wasting time is not advisable. And in few, even transplant doesn't help. So they are untreatable scenarios. So etiology wise, we need to have that's when we approach, we need to have we should know, try to look for on history, try to look for etiology, and examination should look for any possibility of a liver disease because it can be the first presentation of the chronic liver disease. So pathophysiology wise, we have either it can be a necrosis where there is a viral infections where there is a lot of cellular necrosis and enzymes are very high. Here the presentation will be first as an hepatitis and then it will progress to an increase in bilirubin. They may or may not recover. In toxic or metabolic one, they generally have a apoptosis of the cells, and if we take care of the injury in the early phase, there is a chance of recovery. So that's why picking those cases at early phase is important. And they mainly, the enzymes are not that high in this kind of etiology, and they have high bilirubin and ammonia. And if there is an underlying cirrhosis like tyrosine and Wilson disease present at the first time, here again recovery is very remote. So once we have a liver failure, it's a multi-system disorder because there is a release of lot of toxins, and there is a significant systemic inflammatory response syndrome, and affects multiple organs. So liver failure is a multi-system involvement, is not only one organ. And to the end, in all this, the ammonia goes up, and the brain edema is causes encephalopathy, and that affects the survival. So when the patient comes to us, we have to confirm liver failure. So by definition, we know we look for an INR, and clinically we look for encephalopathy, prove that this is because of a liver function or liver dysfunction. To look for severity, we have a few tests look for any lactate, look for electrolytes, renal dysfunction, INR, ammonia, sugars, and to look for infection, look for CRP in blood culture. And there are few tests that we look for etiology. So that all depends on severity. If you have a child who has an encephalopathy, probably doesn't give us a time, and we need to do a investigation. If the child is stable, probably we will go in a sequential manner. So hepatitis A, E, and hepatitis B, we look for if there is a history of paracetamol that is not very common in Indian scenario, but sometimes in the accidentally or suicidal it can be a possible. Autoimmune markers and IgG level and ceruloplasmin. These are the important treatable etiologies that we look for. And of course, ultrasound abdomen and Doppler to look for any presentation of acute hyperacute burchialy. In the index case, we have hepatitis A and E, IgMs and workup for B was negative, ceruloplasmin was normal, and his ANA was positive, LKM1 was also positive, ASM is negative and very high IgG. So this child has an acute liver failure because of type 2 autoimmune liver disease. Then just coincidentally, Dr. Vishnu also discussed the similar kind of case. So this child will actually, we see his course in last 3 weeks prior to presentation. He was not encephalopathic and INR was high and it was not addressed, not diagnosed on time, and the encephalopathy progressed, INR gradually progressed, his ammonia that is also increased, and he has very high arterial lactate. So the cause of mortality in liver failure, one is the basically raised ICT, occasionally bleeding, infections, and multi-organ systemic failure. Most of the time we are feared about the bleeding consequences, but percentage-wise for the mortality, it is not that high. Before basically an IC bleed, the patient succumbs because of raised ICT, infections, and multi-organ dysfunction. So so knowing this, we know what are the goal of treatment is to aim to maintain the near normal homeostasis, round the clock monitoring, prognosticate using the available models for liver failure scoring system, and planning for a transplant is not same as the performing one. That one should understand. And what we try to do is to achieve overall metabolic and hemodynamic stability in order to create a condition favorable for hepatic regeneration. So steps of management, we all of know, Dr. Mentees and team has so many modules and the seminars on the ICU management. So we'll not go in details of that. But the crux is early airway protection is important. Treatment should be directed towards raised ICT management, prevent bleeding, antibiotic, antifungal when we are doing an invasive interventions, and to increase survival. What is important here is to take care of intracranial pressure because main mortality is because of that. Supportive measures with the other medications, this is important. So clinically, one should look for any tachycardia. If the child is getting tachycardia, hypertension, any pupillary abnormalities, altered sensorium, that tells us about the raised ICP, and these are the alarm signs when we are seeing the patient for a liver failure. Again, the children with ALF, you should not, once we have taken care of airway or in advance liver failure, don't keep them kneel per mouth for a prolonged duration. So some amount of enteral nutrition is must because it avoids any protein catabolism and also avoids any bacterial translocation. So they also protect it from the infection. So enteral nutrition is very important. And role of NAC is controversial, but doesn't have much survival benefit. One may or may not give it. But of course, in paracetamol, it's required. Younger than 4 years. So again, the role is not very proven. So should we? Another question is: should we correct INR in the absence of bleed? So generally, we do not advise it in the absence of bleeding. But if very suppose one is again, if we give FFP, it basically operates the trend of INR, so which is an important marker of prognosis. So generally, we transfuse if there is a clinical significant bleeding. We are planning any invasive procedure, very high INR, we're planning to shift. Platelet is less than yes, or fibrinogen is very low, then we give cryoprecipitate. So all the time FFP may not be solution. Sometimes they need an FFP, sometimes they need a cryoprecipitate, or sometimes they are 30% are a prothrombotic state. So sometimes they also need Tranexta to take care of the bleeding. So knowing the etiology mechanism of bleeding is important. Another important aspect is that the ammonia level. So the death is directly proportional to the very high ammonia level. So if it's more than 200, you can see the Kaplan-Meier analysis. The rate, the mortality is quite high on day 6 of admission. But if you keep the ammonia around less than 200 or less around 100, the survival is prolonged. So the goal should be, apart from support to care, is to keep the ammonia under check. So there are different ways of decreasing ammonia. So the lactulose, oral antibiotic, probiotic, they are very ineffective and no proven role. So the do a renal replacement therapy and to keep ammonia less than 150. Again, if there is a significant surge, one can support him with the plasma exchange. So when to transfer this child? So when INR is more than 4, they are likely to progress. You see, this child went in encephalopathy in less than 48 hours. If there is significant hypoglycemia with high GIR, also the sugar is not maintained, lactic acidosis which is rising, increase in inotropic requirement, increase in creatinine, these patients, they are likely to progress. So this patient should be treated with that other or advanced center as early as possible. To know that, how to know about the prognosis. One is etiology. We know that with the paracetamol related, we have an antidote. Autoimmune hepatitis, if diagnosed in earlier stage, one can treat. This child has 3 weeks of history and it was undiagnosed. So at that time, if it is delayed presentation, one may not help. Indeterminate or non-astromine drug-induced liver failure, Wilson disease, they have a bad prognosis. King's College criteria we use widely for non-paracetamol associated LF, but it may not work that well in the children. So if we generally based on encephalopathy, and if the INR is progressively increasing more than 4, they would prepare for a transplant. One should know when not to do. So when there is irreversible brain damage, then there is no use of referring the child or any advanced treatment. So we need to act before we reach this stage. Mitochondrial disorders, multi-system involvement, we should not look for uncontrolled sepsis or any systemic disorders. Then we are helpless in such situations. So in the index case, this child, when they came, at that time he went in a grade 3 encephalopathy. Though we diagnosed the etiology, we couldn't help, and this child didn't have any compatible donor, so we have to do an ABO incompatible transplant. He was very sick. He had the convulsions. He had 3 inotropes. He was on renal replacement therapy. Child was ventilated. Then in the emergency, this child underwent a liver transplant, and then he recovered well. If we just go through a few other experience, that we have almost around 25 liver transplant that reached to our center, and 3 went DAMA because of financial issues. You see their labs, they were very high, like lactates were very high, ammonia was in around 200, 60% have grade 3, grade 4 encephalopathy. Spontaneous liver recovery of this was possible in 30% of the cases when they were supported well, and most of them were A and E etiology, but non-A and E, they required transplant. Death was in 1 because of HLH, which was an unfortunate incident. So if you see of all these 25, 20 survived. So almost 80% success rate they have if they have all received all proper care. So take home message is definition of ALF in children is different. So one should not wait for encephalopathy. The encephalopathy is not an essential criteria. Etiological workup is important because if you pick up a treatable cause on right time, they can be salvaged. Supportive measures are very essential. Ammonia control is important in the management. In appropriate cases, transplant can be offered, and now the survival is improving. So that was the last slide.
Thank you, Vibhor. Nice presentation. The message is very clear. Like what Dimple said, while you are handling a cholestasis, gamma GT is important. While you are treating a patient of acute liver failure, INR is important. Don't forget to do INR in any patient who is coming with acute viral hepatitis-like illness, because our previous criteria is to be the hepatic encephalopathy when the patient develop encephalopathy to onset. Now it is no longer valid. In children, it is very difficult to assess the early encephalopathy. So you have to rely on INR. Simple INR will tell you patient is in liver failure or not. And the second important message which Vibhor has conveyed, I will fully agree with him, that the timing of transfer to a center, if you transfer the patient late, then whatever you do, you will not be able to salvage. So the timing is very important. Don't wait till the patient start decelerating. If you can counsel them and they are ready, so if there is a persistence of coagulopathy more than 4 without even hepatic encephalopathy, so it is better to manage this patient in a center where if the patient deteriorates, you can salvage by transplant. I slightly differ with before. The finding etiology will make hell lot of change. It does not. Like autoimmune hepatitis, you had to do transplant, and Vishnu has tried steroid, it didn't work. So when patient develop acute liver failure, whether it is autoimmune, it is Wilson, if it is a severity of the disease, will dictate. Most of the time, you have to do the transplant. Hepatitis A, E, obviously, you don't have anything to offer. Other than paracetamol induced, which we don't see often. The rest of the etiology, yes, we should look for, we try, but we have to be prepared to go for transplant if they qualify for it. Before you want to make comment?
No, sir, I agree with you. So once there is encephalopathy, etiology, the treatment will not make a difference. But the idea is when we are giving any liver dysfunction like bilirubin, even the INR may not be normal. At that point, we should look for etiology so that the further progress can be taken care. Means at least there can be attempt can be made. But yes, after once there is encephalopathy, the treatment won't make much difference.
So, dear attendees on this Zoom dais, everyone has been given permission. If anyone wants to ask directly the questions to our esteemed faculty, they can just unmute and ask the questions. Anyone who are among the attendees.
Sir, we have few questions.
Yes, go ahead.
One question is acute immune liver disease. Is it common in adolescent age? Anyone can answer.
So autoimmune liver disease, so we do see autoimmune liver disease, and adolescent age also it's one of the important cause, as was showed the Western data. After all ALFs, around 5 to 6% were autoimmune liver disease. Out of this 30%, around 20 to 30% do present as an acute liver failure. Other 30% can present as a liver disease, and someone has a slowly progressive course. So we do look for many of them come to us as a subacute or CLT presentation.
Before, will you say autoimmune liver disease, autoimmune hepatitis?
Autoimmune liver disease, sir. Not only hepatitis.
Which other than hepatitis present with acute liver failure? Anyway, that is the splitting here. This is not these are all autoimmune hepatitis. This is the one group of people, they believe that term should be liver disease, but it is actually autoimmune hepatitis we are talking about, which goes into hepatocellular failure, isn't it? Autoimmune sclerosing cholangitis, they don't manifest with liver failure. There is no age bar, but it is not a very common cause of acute liver failure. In day-to-day practice in India, we still get virus. Huge amount of virus, but that's why I was telling on the first case, if you got a case where the serology is negative, then you have to be careful. It may be autoimmune hepatitis, and diagnosing early before the patient is down with encephalopathy might help, but you have to be careful that many of the time the treatment doesn't work. They go for transplant.
We have one more question of autoimmune. Does autoimmune hepatitis reoccur after transplant?
Vibhor?
Yeah. So 5% means yes, it can reappear. They have around 5 to 10% can reappear, and one of the risk factor for the reappearance is if we do not check their autoimmunity before a liver transplant. Like if in a liver failure, when this child has not received immunosuppression before that, so these patients are more likely vis-a-vis those patients who are CLDs and they are been treated for few months or on for with the immunomodulators. There the autoimmunity is little bit under control, and in this patient the chances of autoimmune related react this is less. Now, if I can just tell about further about the same child that I have presented, in just 2 minutes, I will do what happened to this child later. So this child had basically we have to go in with the transplant and within an ABO incompatible setup. Months of transplant, this child has developed a multiple biliary strictures. They were throughout, and they were increase in enzymes, increase bilirubin, and because of autoimmune and AI and incompetent, the and immunosuppression level was quite high. We thought it is a ABO incompatible related biliary epithelium damage. We did all our workup for the ABO antibody mediated damage, but it was not there, including biopsy, donor specific antigen, and marker. But then it turned out to be it is a sclerosing cholangitis this child has. So it means the recurrence and the continuation of the autoimmune process can continue in such situations. Now this child so he is on now 4 immunomodulators, and with this his autoimmunity and the inflammation is under control now. He's now 6 months post-transplant.
Just one question, I will ask to Dr. Dimple. Dr. Dimple, you said if the biliary atresia is operated before 2 months of age, then success rate is quite high, and 50% or so will be left with nascent liver till 13 to 15 years. Is that a cure, or at some point of time they will still need a transplant? Is it a cure, or they will always need a transplant later on?
Yes, sir. So one is that what we said, 50% survival between 12 to 15 years of age. That is if they are operated less than 30 days of life.
Perfect.
For those who are operated less than 60 days, the survival comes down almost 20 to 30% will make it to 12 to 13 years. Having so these are some studies which are there, but then there are patients. So we don't know exactly in percentage. I may not be able to say. Maybe sir might be able to add. But there are patients who have done only Kasai and they have survived till 65 years of age also. So Dr. Kasai, in fact, the one who started this photoenterostomy, he has a photo with a 65-year-old patient of his who is operated for biliary atresia and who's surviving. The percentage, maybe sir might be able to say full life.
Mahesh, you raise a very important issue of what we are doing. Are we doing justice to these biliary atresia cases in India without having liver transplant backup? What Dimple said is correct. Now we have data of long-term survival of biliary atresia, not 10 years, 15 years, 25 years survival, because most of the center have accumulated their data. In general, it is just 25% of patients they survive with native liver beyond 25 years. This figure is higher in Japan because the technique is much better. They started this Kasai earlier, so they have refined this technique, and their figure is almost 50%. Means 45 to 50% of children who are operated less than 60 days of life, they survive with native liver beyond 25 years. Now your question is, are they cured? Now we have a very interesting study from King's College. They say those babies who are surviving beyond 15 years and you do their liver biopsy, 90% will have changes of chronic liver disease. Only 5 to 10% actually, so-called cure is actually 5%. These 90% figure, including 40% already have cirrhosis, and rest around 50% will have changes of chronicity. So what the speculation is that biliary atresia patient probably at some point or the other probably may require transplant. But the very interesting hypothesis now, that what we know about the kidney transplant is kidney transplant the transplanted kidney has a shelf life. If you transplant a kidney to a 10 years old boy, he is not going to have the whole life with the same transplanted kidney. You will need after 10 or 15 years. So far, our perception used to be the liver you give, it is a whole life, but that is the adult figure. After 20 years of transplantation, at least 1/3 of the transplanted liver is showing fibrosis. And another a significant proportion of the patient who receive liver transplant, you knocked off their kidney by using all this toxic drug. So if you transplant a 1 year, 2 year, 3-year-old boy with biliary atresia, maybe after 20 or 30 years down the line, this boy will require another liver transplant or kidney transplant or combination of both. So what will be the target? Target should be you keep them alive with native liver as long as possible. If they are alive at 25 years and then he is going for transplant, so probably he will live his life with one transplant only, that is one liver transplant. So that's why now focus and bar has changed. We need to pick up biliary atresia early, try to operate them in first 30 days so that at least 50% of them will have a native liver survival of more than 25 years. Mahesh, that will...
Yeah, absolutely, absolutely. Just one more question, if you allow me. What are the overlaps of biliary atresia with alagais? Like I recall seeing one of the child who was operated as biliary atresia came to us on 5 years, and child was in fact had we detected some anomalies, sort of dysmorphism, and worked up, and then reported as alagais. I mean, is it a known kind of overlap, or it's kind of something which is missed?
Dimple, you want to answer first and then I'll supplement?
So one is some are wrongly labeled biliary atresias. So even in allegeals, if we do a very early biopsy, that is within the first month, it may not pick up paucity of bile ducts because paucity of bile ducts typically appears after 3 months of life. So they may be one wrongly diagnosed biliary atresia. And secondly, there is a entity of biliary atresia associated with Alagille's syndrome. I don't know the exact incidents again, but when I went to King's, there they used to routinely discuss this because even in biliary atresias, they used to send genetics for all because probably NHS is free. And there they used to say this entity. Even I was surprised to know this, that biliary atresia with allergies, but I didn't find any literature again when I came back. But I've heard them talking about this. So Professor Davenport used to say biliary atresia with allergies. So I don't know.
No, Dimple, this perception came because many of those so-called biliary atresia operated turn out to be Alagille syndrome on follow-up, because when you are relying on paraoperative cholangiogram, these Alagille syndrome babies, they have hypoplastic bile duct. And if you are not careful while doing paraoperative cholangiogram, you misinterpret them as biliary atresia, you do photointestomy, and they don't do well. Their prognosis is worse. That's why this perception in Kings came. But I don't think there is a hardcore evidence of combination of biliary atresia with Alagille syndrome. But Mahesh, you are right that if you are not careful while doing paraoperative cholangiogram, you may misinterpret that hypoplastic bile duct as biliary atresia and do the Kasha, and after that you discover it is actually Alagille syndrome.
Just one comment. Many times, like many surgeons, they see, okay, I didn't do perioperative cholangiogram because I couldn't see the bile duct. So they are missing there, or sometimes they overdiagnose the biliary atresia in the allergy. So we must insist have to have a POC and documentation and the X-ray plate of a POC after biliary atresia.
Excellent.
There is one question for Vishnu sir. Acute Wilson disease. For acute Wilson disease, how is predictor value of ceruloplasmin?
The value of ceruloplasmin will not predict the Wilson disease, but if you get a value in single digit, as Buddha sir said, so that will diagnose or make us suspect and have a high index of suspicion of Wilson. But the low value doesn't mean it is a bad Wilson.
See, this is a very important issue of cellular plasmin, interpretation of cellular plasmin in a patient of acute liver failure or chronic liver disease who is having very low albumin. So the concept should be you should not delay or defer the treatment. If it is not Wilson, giving depenicillamine is not going to harm. But you should keep the option open. See, when the albumin comes back to normal, you repeat the ceruloplasmin. Wilson disease, you will never get a patient whose ceruloplasmin will become normal after improvement of albumin. So after 3 months of Wilson disease you are treating, suspected, the albumin become normal, repeat the ceruloplasmin. It becomes normal means this is not a Wilson disease.
Also in ALF, it can be typically less than 5. In Leipzig score, they give a lot of importance. So ceruloplasmin of less than 5 directly more points.
No, so that's why I see the Dimple and Vishnu that whenever we are talking about autoimmune or Wilson, we use score. What does it mean? There is no single biomarker. It is very difficult to diagnose. That's why you are collecting more information, putting them together, and try to dissect out how many score will be more diagnostic. So don't rely on only single value.
There is one more question. Best or recommended time, day of illness or sign to do INR and ALF patient suspect?
So, what is the question? INR timing.
Best or recommended time, day of illness or sign to do INR in ALF suspect?
So when you are suspecting ALF, you have to do immediately. Then you don't have to wait. So and means you are getting any jaundice in a child, it means there is some liver dysfunction. One thing is, suppose you are getting a lab report of liver dysfunction where only enzymes are elevated and probably bilirubin is normal. There, yes, there is a hepatitis going on. Probably it has not reached to the state of a dysfunction, except some like race syndrome or somewhere. There we may not do an INR because it takes significant amount of blood volume and also the cost. But if you are getting any liver dysfunction with elevated bilirubin, one must get an INR at that point. And then depending on how much is the INR, we can decide when to repeat. Suppose INR we are getting a prolonged, then we'll give vitamin K and maybe next day we repeat. So then there are a lot of scenarios when we determine how we are getting. But the patient is admitted and there is a prolonged INR, child is sick. In that time, we need a more probably aggressive INR monitoring. Like probably in the setup like transplant setup, we will be doing every 12 hourly or 8 hourly. Where there is INR is not that deranged, we may do once a day. So they are all situation dependent monitoring.
Yes, sir. And one more last question is red flag sign of AVH progressing to ALF.
So one thing you have a documented acute, suppose you had on an OPD basis, you have an acute virus hepatitis and you know, okay, so a hepatitis there and the patient is coming to an OPD. One of the important things first is the clinical examination. Once the patient comes to document what is the liver span, and on the daily basis is when a patient comes, is your liver span is regressing. So it means the liver mass is contracting. Is losing the liver mass. Second thing, what happening to the child's day-to-day behavior? It affect the cognition, affect the personality. So is the child is usual self? If the small child is there is an irritability. If the baby is there is an alternation in the sleep-wake cycle. Is the child is not eating well? So this will be the early signs of encephalopathy. So on the clinical basis, this is how we will see whether we are getting progress towards the liver failure or not. And then of course, and appearance of a jaundice, probably liver disease may be progressing. Of course, there's a one component of cholestasis. Let's not go in that. And biochemically, what's happening to the INR. So that's how we will monitor them on OPD basis. So anything, sir, you want to add further, sir?
No, absolutely fine. See, the acute viral hepatitis, the first and foremost thing is you do a INR first. If INR is abnormal, you are very careful of monitoring. INR is normal, child is doing well. What is before us highlighted is very important is measuring the liver span. If there is even in the deranged INR, The increasing liver span is assuring child is recovering. Decreasing liver span is child is deteriorating. So that is very important besides monitoring the mentation, because in a smaller kid, irritable child, it may not be accurate to say whether child is having encephalopathy or not, but more semi-objective is your liver span and INR. These two are the most important.
Okay, so one more question. How to treat sickle cell hepatopathy? Vibhor sir?
Yeah, so the sickle cell hepatopathy, it generally the liver disease is advanced. I don't know. I don't think you can treat it. You have to treat. You have to control the ongoing hemolysis. The treatment is with the hematologist, and damage is already occurred.
Sickle cell hepatopathy, there is no specific treatment. It is one of the advanced stage of sickle cell disease. So we need to just take care of that. I don't think any special thing we do for sickle cell hepatopathy. There is basically a bad prognosis when they go for hepatopathy. Neha, it is becoming too late.
Yes, sir.
Yes.
Yes, sir. So now we will proceed for the vote of thanks. I will invite Dr. Ramon Pawar sir for the vote of thanks.
Thank you, Neha. It's almost 2-hour session instead of 1. I take this opportunity to thank mentor Dr. Ujjal Poddar sir for agreeing to be mentor for his Mentees trio from Maharashtra on Maha platform. Sir, you have guided your mentees and all pediatricians today with all your practical inputs on various liver topics and cases as well. Thank you, sir. I also thank Dr. Vishnu, Dr. Dimple, Dr. Vibhor for taking time out of their busy schedule in making very informative presentations and also discussing various clinical case scenarios. We appreciate your efforts to pass on many practical inputs to all pediatric intensivists and general pediatricians as well. I also thank MMC observer, Dr. Sachin Wahadnes, senior pediatrician from Ahmednagar. I thank Dr. Neha for moderating today's very important session. I also thank President Dr. Hemant Gangulia sir and Dr. Pallavi ma'am. Incomplete without interactive audience. Today we have almost full Zoom and also 260 delegates were on YouTube. I thank all of them from Team Maha. Next Maha program will be on Saturday. It is Maha Katta with Dr. Sandhya Khadse Madam, senior IPN who have worked a lot in the field of importance of breastfeeding and human. I thank all the delegates. I thank all the faculties. Thank you. Good night to you all.
Thank you, Amol. Thank you, Hemant and Maha IAP for giving us the opportunity.
Thank you very much, sir. Thank you very much.
It was our pleasure, sir. Thank you, sir.
Thank you, Neha.